Hello, I'm Dr. Anthony Wheeler, and I'm here to tell you everything that you need to know about pathology. Now take a look at this image here to the right. That's the same child seen at different intervals. You see the changes to their face, particularly the lips? See, this is why I'm proud of all you future plastic surgeons out there. You're out there doing great work. Imagine the difference in life that this young child will experience looking like they do in C growing up opposed to looking like A in growing up. Not to say that abnormalities shouldn't be embraced or whatever, but just imagine the less bullying, awkward looks, questions that this person's going to experience through their life because a plastic surgeon did this. Truly outstanding work. We're going to be talking about this and much more in this presentation on oral cavity pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan this QR code to get to the updated lectures and the updated material, the online resources to help make sure you can do your best on Step 1 and with your coursework for pathology, and also to have as a backbone as you progress through medicine, right? Because it all comes back to this. It's all tied together. You can never escape it. You think you're done after Step 1? You're in for another thing. Remember everything. So we're going to be talking about oral cavity pathology, okay? Oral cavity pathology includes the cleft lip, cleft palate, aphthous ulcers, Behçet syndrome, oral herpes, squamous cell carcinoma, leukoplakia, oral candidiasis, hairy leukoplakia, and erythroplakia. Okay? Let's start with the cleft lip. If you remember back to embryology, the 5 facial prominences grow and ideally unite to create the face during the early stages of pregnancy. The 5 facial prominences include 1 superior, 1 left, 1 right, and 2 inferiors. A cleft lip is a full thickness lip deformity brought on by the failure of the facial prominences to properly fuse together. Cleft palate frequently coexists with cleft lip, like what we can see in this image. This is status post an operation, but note how the lip is swollen from the surgery. But it looks more natural within weeks, right? Compared to some of the other cleft lips that we've already seen. For example, pre-operation cleft lip. Here's another case of median cleft lip, preoperative and postoperative, right? Fascinating. So what's a cleft palate? Well, a cleft palate is a complete thickness deformity in the palate that results from the inability of the facial prominences to fuse. Cleft lip frequently coexists with the cleft palate. Therefore, cleft palate frequently coexists with the cleft lip. A single cleft palate is less frequent. And here we have imaging from a 64-year-old patient that had a repaired cleft palate. Now let's talk about aphthous ulcers, which are painful, superficial ulcerations of the oral mucosa. Aphthous ulcers develop as a result of physical strain, trauma, or friction. Typically, aphthous ulcers have a gray foundation encircled by blush red erythema. And be aware, if you see an aphthous ulcer in real life, you still need to keep your differential open to other possibilities for the lesion, such as herpes infection, angular cheilitis, or maybe that person just needs some Burt's Beeswax on their lips or some chapstick. So here we can see the aphthous ulcer on the lower lip, right? Near the labial mucosa. Note that halo surrounding the ulcer. Halo appears a bit reddish, a bit erythematous, right? And here we have the histology of an aphthous ulcer, right? Note the ulcer edge near the epithelial layer. And speaking of aphthous ulcers, there's a syndrome that is associated with aphthous ulcers called Behçet's syndrome. Now, this syndrome also presents with uveitis and genital ulcers. Behçet's syndrome is an immune complex vasculitis of the tiny vessels. Wow, vasculitis. Hey, we've talked about vasculitis, right? And I'm sure you've seen them throughout your coursework. So while we're on the subject, we have some large vessel vasculitides, some medium vessel vasculitides, and even some small vessel ones, right? Do you remember at least one large one? Maybe giant cell arteritis or Takayasu, right? You remember those. One of them will cause blindness if not treated, right? Temporal arteritis, right? Which is also known as giant cell arteritis. What are the medium vessel vasculitis? Do you know at least one? Maybe Kawasaki disease, right? You remember that? Or polyarteritis nodosa, right? And lastly, what are some small vasculitises, or vasculitides, I should say? Microscopic polyangiitis, right? Eosinophilic granulomatosis with polyangiitis, right? You remember that? These words sound familiar. But back to Behçet syndrome, right? Keep in mind, Behçet syndrome has this aphthous ulcer, along with the other features of uveitis and genital lesions. So here's a patient with Behçet syndrome, highlighting their oral ulcers, the aphthous ulcers. And for my MD PhDs out there, I haven't forgotten about you. I know I'm always showing love to the future radiologists and future pathologists and future surgeons, heck, the future pediatricians. I'm never showing love to the MD PhDs. Well, let's change that. See, just for you, I have this 3D representation of HLA B51. I'm glad you guys like research. Let's put it that way. Now let's move on to oral herpes. These can present as lesions in the oral cavity that are painful, red, and ulcerative, right? Take note of this image of this herpetic gingivostomatitis. Now, what's the most common cause of oral herpes? HSV1. What's the most common cause of genital herpes? HSV2, right? Just for, closing that loop. Now, that doesn't mean that HSV2 can happen in the mouth or HSV1 on the genitals, but we're talking about most common here, right? So remember that if it's most common in the mouth, it's going to be HSV1. Right. So, the initial oral herpes infection typically strikes children and preteens. And the herpes virus remains dormant in the trigeminal nerve ganglia after the initial sores have healed. Stressors like tension, heat, sunlight, having to study for step 1, etc., can make the herpes virus reactivate. The red pimples and ulcers return when the virus is reactivated. Here we have histology from infiltration of various inflammatory cells from the upper to the lower dermis, showing perikeratosis and irregular acanthosis, right? Neutrophils, all of this associated with some fungal hyphae. This is tinea incognita, simulating herpes simplex virus infection, right? That's why biopsies are important. That's why pathologies are needed, right? Because clinically they thought this was herpes. Said, no, got that biopsy, processed it, and at the microscopic level, saw something that probably was left off the differential, right? So that's why we need more medical professionals with the astute skills to give our patients proper diagnosis. Especially when it comes to squamous cell carcinoma, which we're going to talk about now. Squamous cell carcinoma is the second most frequently caused cancer in the world, or frequently diagnosed cancer worldwide, I should say. Squamous cell carcinoma accounts for about 30% of cancer cases in men and 20% in women. Now, 2 important risk factors for SCC, as you know, are alcohol and tobacco. Invasive squamous cell carcinoma may develop from oral leukoplakias and erythroplakias, which are precancerous diseases or precancerous lesions. Although they can appear anywhere in the oral cavity on that epithelium in there, these lesions typically grow at the bottom of the mouth, right? On the floor of the mouth specifically. And histologically, squamous cell carcinoma is identified by alterations in the stratified squamous epithelial layers, such as invasion into the underlying connective tissue, and hyperkeratosis, perikeratosis, acanthosis, and keratin pearls, as well as dysplasia. For example, we can see some of those microscopic features here. Note the intercellular bridges, the keratization, the abundant eosinophilic cytoplasm, right? This is some classic squamous cell carcinoma histology or histopathology. Can you see the squamous pearls here, or at least the squamoid features? This is squamous cell carcinoma. Highly likely that you might see this, right? This is fair game. Now let's talk about that precancerous lesion, leukoplakia. Leukoplakia is a frequent premalignant lesion of the mucous membranes of the mouth, throat, larynx, esophagus, and even the genitalia. It's sometimes called patch disease. A white spot on the tissue surface that cannot be removed is the hallmark of leukoplakia, as we can see here in this image. Usually, neither bleeding nor ulcers occur in leukoplakia. Thrush or oral candidiasis and leukoplakia are completely different entities. They're not the same. Thrush is not leukoplakia. Leukoplakia is not thrush. Also, hairy leukoplakia should not be confused with leukoplakia. So here we can see leukoplakia, right? Leukoplakia, the exophytic form on the buccal mucosa. And here we have more imaging showing mild dysplasia and oral leukoplakia. Now this is oral candidiasis, right? Looks white, but it's not oral leukoplakia. This is different. This is oral candidiasis. Now, as you know from microbiology, Candida is a yeast, right? Candida is a yeast organism that is often present in minute amounts in the regular saliva. And it is a frequent cause of oral thrush infection. Candida generally is harmless to healthy individuals, but overgrowth can happen in people whose immune systems have been compromised by disease or drugs. As a result of oral candidiasis, the tissues in the mouth become inflamed and thrush, that whitish crust or coating on the tongue surface, develops. Risk factors for oral candidiasis include antibiotic use like penicillin or cephalosporin, cancer chemotherapy drugs like cyclophosphamide, even steroids or radiation therapy, HIV/AIDS and their medications, organ transplant recipients, because they're immunocompromised, diabetes, weakened immune systems in general, severe burn injuries, and leukemias, right? So oral candidiasis can lead you to think that this patient has something going on that must be addressed. So that might be a key feature that leads you to do a thorough workup on multiple systems. Now, thrush can occasionally progress into the potentially dangerous disorder known as oropharyngeal candidiasis. And here we have an image of candidiasis affecting a patient with HIV. And here we have oral candidiasis in an infant with an immune system that's not properly developed yet. Now look at this whitish palatal ulcer that was detected at the time with the diagnosis of oral candidiasis. Now let's talk a bit about hairy leukoplakia. This is a condition that manifests typically with HIV infection and is distinguished by parakeratosis of the oral mucosa, hyperkeratosis, and keratinization of the epithelium, as well as numerous intracellular inclusion bodies made up of these lipid vacuoles that have this concentric lamellar structure and occasionally viral particles within macrophages. Regarding hairy leukoplakia, these oral sores are very contagious and frequently lead to the development of systemic diseases. On the other hand, erythroplakia is a red plaque that is a tissue lesion characterized by thickened epithelial mucosa with areas of white plaques. Erythroplakia is also known as vascularized leukoplakias. These are the red plaques that are associated with oral cancer. Erythroplakia usually occurs on the gingiva, buccal mucosa, lateral tongue surface, the floor of the mouth, or the retromolar trigone, for all you future ENTs out there. These lesions are most commonly found on the anterior surface of the maxillary alveolar ridge, but they have been reported to arise on the hard palate and the vestibular sulcus and soft palate, right? And with that, this lecture is very important. Not like all the other lectures were important, but we hit on some high yield things here. You're going to see a lot of questions that come from this. And more importantly, you're going to see a lot of this on the clinic side, right? So keep it in mind. Let all of this become One with your mind. Because it's going to keep coming up, right? Let me know if you have any questions, comments, or concerns. I'm here to help you. And I'll see you next time. Till then, keep up the good work. Ciao.